Hi, Fernanda. How are you? How was your day?
Hi, Doc. Everything's okay.
Perfect. We are together now. Yeah, let's wait to the rest of the group. We are o'clock. Well, it's 8:05. Fernanda was here, but maybe something is failing with the internet connection because nobody else is coming. Let's wait a little bit, I think, and well, I don't know. Fernanda, it's 8:04. Maybe it's 8:05. We can say. If you want, we can start now, or maybe wait a little bit more because we are just two of us. Maybe we can wait 3 minutes more, and then if they don't attend, well, we start, and I hope they come. Let's wait a little bit, please. Good night, Denise and Alejandro. Well, at this point, we are only for attendance. If you want, we can start now or maybe wait a little bit more because there is no quorum. Yeah. So it's your choice. That's okay for me.
I prefer to start, Doctor.
Yeah. Dennis, do you want to start now? Does it fit to you? Fernanda? We can start, and according the rest of the students come, well, they have to check the video or take the information from the slides. It's okay for me.
If everyone is okay, let's start. Let's go ahead.
Okay, let's go. So let me share the screen, please. Give me 1 minute to do that. Wait. Please let me know. Can you watch my screen?
Yes, we can.
Perfect. So let's go ahead. Let's go ahead. We are studying at 8 and 8. Yeah. And I think it's a good moment to do that. Well, this class is not too long, talking by our slides, but we have to take in account that here we have lots of new terms, new vocabulary, and expressions to consider, and this presentation maybe look like a not comfortable one because we are going to talk about epidemiology. And we all know that epidemiology is not the best topic for us. I mean, at least for me, it's not my favorite point of view, but well, patience, we have to do this. In that order, let's go ahead and well, let's do this. Today, we are going to check a general view of screening and immunization. The immunization for general concepts, I mean, because if we try to get in touch with all of the vaccination programs around the world, the most common ones, we are not finishing the class. It's too much information. And vaccines as a general view, of course, everybody knows their own national programs. So they don't have too much differences about doses or the periods that it has to be applied. So it's not the topic today, just general view. About epidemiology, we're going to get in touch with lots of concepts that we got in mind during the medical career, and then we use them throughout all our life, I think, because we are following investigation, I mean, and then we use the terms. And medical ethics, of course, we all know what it means. So let's go. About the screening and immunization, of course, we all have the idea about this topic. I mean, we have in every country, each country of us has its own programs and has the good way of working like this, trying to look for the best of their own people, trying to conquer the fight against some infections, diseases, and well, that's why it's important. The screening term, we have to check and we have to remind that is a way of identifying people. That way of identifying help us to check our population, okay? People at increased or greater risk for a condition, for example, COVID-19 could be one good example, or maybe parotiditis, or maybe rubella, or maybe, well, lots of infectious diseases, tuberculosis, we all know about it. So, although they do not yet have any signs or symptoms, we have to work on this part. Without the clinical trouble, without the clinical situation, we must take activity and get in contact with our patients and prevent any situation with vaccinating. In some cases, mass screening large numbers of people is appropriate. Well, why mass screening? Of course, we all know about it. We all have the experience of this. So, for example, in the past for tuberculosis, we all know it was for everybody the vaccine, and we all have to follow this and receive the doses. Because it's part of our national program in every part of the world, I mean. In other cases, only those with high risk factors like family history of conditions such as cancer and diabetes are screened. Why cancer? Because we know that there are vaccines against cancer. At this moment, we have the cervix cancer that has its own vaccine, following the papillomavirus, I mean. Diabetes is now in studies, in research, but it's still a dream, I think, at the moment, but we can get this information. However, there are a number of problems with screening. There are always false negatives. False negatives are the cases where a patient has a disease, but screening does not identify it. So it happens, we all know about it. And there are also false positives, where someone is told they have the disease, when in fact they don't. Okay, it's a very common situation. We all know that in medicine, nothing is 2 + 2 and 4. It's not possible to be and to act in that way. We always get in surprise, and those false negatives and false positives are surprises that we get and we catch every day. Furthermore, with some diseases, early identification is no benefit to the patient as there is no treatment available. So, taking this information, we can understand this, that we have a list of common screening tests. This list, of course, is for Europe because our principal book is based on the UK book. So in that order, following this information, we can get the idea that considering the condition, we have a specific test, we have a specific population, and we have a frequency to develop the test. In that order, we can get the prevention could be of the red bulb, the red light about a condition. In this chart, we have the primary one and the secondary prevention. We all know primary, secondary, third, and fourth prevention levels. This chart is talking about it. That's why it's not just considering vaccines, it's considering all situations that can be screened, studied, made research, and then prevent taking this activity, the screening test. For example, the neural tube defects and Down syndrome risk, we have the alpha-fetoprotein, the AFP. Subjects, our population in the study, of course, pregnant women, between 16 and 70 weeks of pregnancy. We all know about it. And almost all of the programs around the world have this test apply or is indeed the care of the pregnancy. And then it's easier to get the information and get the correct data for taking all the activities that that patients, that population need. And of course, to improve the attention as a country, I mean. As I was telling you, breast cancer, cervical cancer, the specific test, the mammography and the smear test, we have, of course, in women and between the range of ages. And it's supposed to be every 3 years, depending on the situation. Of course, it has exceptions. Cardiovascular disease is a general view in many countries, USA, UK, French, India, China, use the blood cholesterol. It's not very common in our countries, but we should try to apply this test in order to follow the risks that this condition is causing to our patients. Subjects or population, people older than 40 years old with high risk factors. And it's recommended to make it every year. It's a recommendation just. In the secondary prevention, of course, when we had the problem, the cholesterol elevated to the 4th percentile, we have to continue the test with patients specifically with heart disease every 6 months in order to control the situation and take the correct activities and medication to avoid more cardiovascular conditions. In secondary prevention too, as an example, we have the diabetic retinopathy. We developed the ophthalmoscopy looking for some complications. We were talking about it in the first presentation of this model. So just as an information, in many countries like USA, it's part of the program into the attention of the population with diabetes. So it's very important to consider that it's a cause of blindness. That's why we follow this test. Subjects, of course, patients with diabetes, no matter the stage, and every year. Every year, depending on the situation, maybe twice, maybe 3 times. It depends on the case. Then we have this list. There are some common screening tests. And, well, we just have to consider them as an information because we have to take in account all of this. For example, we were talking now about the pap smear for cervical dysplasia or cervical cancer, of course. Fasting blood cholesterol for heart disease. Fasting blood sugar for diabetes, depending on if there is any risk or not, depending on the age and everything we all know. The BP for hypertension, of course, mammography for breast cancer. No, it's not the most common, not the first option by recommendation, but it's a screen test that is cheap, non-invasive, easy to repeat if it's necessary. It has benefits, okay? The PSA test, of course, the prostate-specific antigen to prostate cancer, fecal occult blood, for colon cancer, of course, ocular pressure for glaucoma, very important situation, PKU test for phenylketonuria in newborns, and TSH for hypo or hyperthyroidism. Both of them developed during the first 5 days when the newborn is with family, I think, or into the hospital if it's necessary to gain the time. For example, well, talking about the immunization for travelers, we must consider this. We are doctors, we might have lots of opportunities to go to other countries for learning, for studying, for teaching, and taking it in account. It's our obligation, maybe it's a good way to say that, to get these vaccines that are occur around the world in order to understand that we are not alone. We have to consider that all of these situations are in order to protect the health of people in other countries. That's why travel vaccines are specific immunizations given to travelers. It's a requirement to get all of them in order to get the pass and then can take off the the travel in general. The specific immunization is given to travelers prior to going to certain areas. It depends on the place you go, the vaccines you need to protect them for acquiring serious life-threatening diseases. Protect yourself and protect the rest of the people. That's what I want to say. What does fully vaccinated traveling mean? Of course, you as a traveler, you're not going to take 20 vaccines because taking a flight, right? Previously of that, you just consider the place you are going, of course. And as a general concept, if you have received both doses of an accepted 2-dose vaccine series, regardless of how long it has been between doses, you are considered fully vaccinated. For example, here in Bolivia, we are endemic with yellow fever. We really need the yellow fever vaccine to take a flight to go to the airport and leave our country. The same as a situation with malaria, just as an information. In this slide, I got it. It's from the last year, 20 and 22. We have the list of vaccines for travelers, the general one, without considering the COVID-19. Why not? Because depending on the place you are going, the country you're going, or the continent, you have to take a specific vaccine of COVID. That's why it's not here. But taking in order the other infections, you have the list what vaccines you need to go to that place. For going to Europe, you have to get the anti-influenza virus vaccine. For going to, I don't know, Central and South America, anti-influenza, anti-yellow fever, malaria vaccine, rabies vaccine, typhoid, hepatitis A and B. So you can see it's different depending on the general chart of the infectious diseases at the moment you are going. Now, for traveling by flight in these times with COVID, you need the COVID in the day or maybe the previous day. Not a week, not 2 days, not 3 days, the day or previous. It's better if it's less than 24 hours. If you don't get it, you cannot use the flight, you cannot take off the flight. That rules are rules and we all have to follow them. Even it doesn't matter if we like or not to take this kind of prevention. It's not a choice. Moreover, we have this chart. This is a picture from from the book. And we have some vocabulary here, some terms that we must check, okay? The following vaccinations are recommended for travelers to South Asia. Just as an example, hepatitis A or immune globulin Ig, because it's a virus that the infection, the transmission can occur person-to-person contact. This expression, person-to-person, always have to get the hyphens. If you don't get it, it's not expression. It's just a grammar rule to remind. So in that order, person-to-person contact could be in another way, person-to-person therapy, for example, or face-to-face is a variable of this expression, okay? Throughout exposure to contaminated water, ice or shellfish harvested in contaminated water. So you can see with hepatitis B, we have the expression exposed to, they go by hands, I mean, that's a compound verb, and you have to use this together, never with something in the middle. Exposed to blood, exposed to urine, exposed to cough, exposed to any fluid. That's the way to use this. Or as you can see here, body fluids, that's okay, that's perfect. The Japanese encephalitis, if you plan to visit rural farming areas and under special circumstances, such as known as outbreak, the outbreak is the moment when it begins. just for catching the vocabulary, okay? Then you need malaria, rabies, typhoid. So I think just checking this vocabulary for having an information slide, an information chart. As needed, boosters, the booster doses for tetanus, diphtheria, and measles, and one-time dose of polio and adults. So let's consider is that the boosters are important at this point, just with these examples. Okay, going to the next. Talking about epidemiology, as I was telling you in a general, very general view. First of all, the concept, okay? Epidemiology is the study of the distribution and determinants of health-related states or events in a specified population, and the application of this study to the control of health problems. So it's a very huge branch in medicine that takes all of these activities that we have to consider, and it has lots of resources to improve. Epidemiology is, in my opinion, one of the bases of research, of course, because we value the situation, we take the information, we prepare all the data, and then we make our report in order to learn as a group all together and find the solution. In this chart, we have the feedback between the public and healthcare providers, such as clinicians, laboratories, and hospitals, and the reports to the health department. The health department asks a question, receives information from the public healthcare system, to the public healthcare providers, they make their report, the report comes to the health department, they analyze the information and make new requirements. And it's a cycle that it's never ending. That's why as doctors, we make research. We just have to be organized in order to do this. And as I was telling you in previous presentations, we have to get the correct studies, the correct preparation for this branch. Now we have some terms that are not very useful, not very comfortable to us. The rates. But rates, of course, are important in order to read research, to understand research, prepare, and show information. At this moment, well, I tried to write down as simple as I could, not mixing terms or making it so difficult to check and catch the general idea. Rates are the speed or frequency with which an event or circumstance occurs per unit of time, population, or other standard comparison. So we got this idea. We have to check that this information could be sometimes some little bit hard to understand, I think, but we got that. We can catch all we need. When we talk about rates, we remember maths. And remember in maths, we know that we have some formulas to practice and to talk about it. But when we talk about frequency using word combinations with rate, we have these grammar rules, this way of expressions, okay? For example, birth rate is the number of births in a population. Death or mortality rate, the number of deaths in population. Case fatality rate, the number of deaths from a particular disease. survival rate, the number of patients still alive after a treatment for a particular disease. So we cannot say just birth. We need the last name rate to understand what we are talking about, and what kind of information we are going to understand to practice. And then, for example, in these bubbles with our blue guy, we know that the birth rate in Singapore, for example, is 10 to 2 per 1,000 population. Another way to express this, the infant mortality rate in Singapore is 3 per 1,000 live births. So you can see just a way to express, a way to read this, but the correct way is the one is expressed here. Other words to use to talk about frequency: common, uncommon, and rare. Malaria is common in many developing countries. Malaria is uncommon in developed countries. Malaria is rare in developed countries. The developing countries, of course, are that poor countries, the third world countries, said in another terms, but developing countries is the correct term to understand it without making it offensive to the population or someone. As examples, we have these charts that is showing us the distribution of some situations. We have other charts showing the progressive changes in different situations, in different pathologies, and how one can change the statistics through the time, because we have the time here and we have the rate here. And now let's go to more concepts. Yes, incidence and prevalence, of course. Prevalence, of course, the number of people in a population who have the disease at a particular time. This is the formula. Prevalence, for taking in mind a mnemotechnic, could be all cases over population in risk. Incidence, the number of new cases of the disease during a particular time. Again, the mnemotechnic. Incidence, new cases over population in risk. So you can see the definition, I think at this moment, is clear. Talking about this, we have to consider again more expressions, ways of talking about it. For example, the incidence of malaria is high in many developing countries. The incidence of malaria is low in developed countries. So you can see we are showing the same information than here, but with another expression, right? With high and low. For example, the incidence of HIV infection is highest in sub-Saharan Africa. Another way, the incidence of HIV infection is lowest in the Caribbean. Note, you don't say the incidence of malaria is common. Common is not a good way to express this, because it's not the correct expression, the correct word. Okay, that's the way to understand this. The incidence of a disease is different. Groups are often compared. You have to compare when it's common or uncommon, when it's rare. But to say the incidence is common, no, we are checking that the incidence is high or is low. That's all. Another way is to express that. For example, rheumatoid arthritis is more common in females than in males. Grammar rule that we all know about it. Rheumatoid arthritis is less common in males than in females. You can see the opposite idea. In another example, men and women are equally affected by restless leg syndrome. So you can see we have the opposites. We have another way, the expression equally affected. less common, more common with the than as a helper, and then it's just a grammar rule, even used in the social English. That's why we can talk about it without any trouble. Another concept, association and causation. This is studying the incidence of a disease in particular groups of people can lead to the discovery of causation, what makes it occur. For example, the high incidence of lung cancer among cigarette smokers suggests that smoking is the causative factor in the development of lung cancer. We all know this idea. We all have the meaning of this. However, care must be taken not to assume every association between a disease and a measured variable is causative. To say there is an association between two things simply means that they occur together in a certain situation. What it means, we don't have to be extremely sure and ensure that because something directly, unless it has lots of studies supporting the idea, we don't have to avoid the idea about associations. Associations in causes, we all know that very common in medicine. For example, several studies have indicated high rates of lung cancer in cooks, not just with smokers. In cooks, we also have this same risk factor. Although this could be a consequence of their work, cooks, perhaps caused by carcinogens, in fumes from frying. Okay, the fog can cause this while cooking, it means. It may be simple because professional cooks smoke more than the average. In other words, smoking might confound the association with cooking. In this example, we have two variables that are being the causative, the cause, two risk factors to be the cause for lung cancer. In this chart, we explain the same idea. Risk factor, low CES. CES is the social determinant that talks about these developing countries. But it's another expression. I'm going to send the meaning to the group. At this moment, it's out of mind. I'm sorry. Well, when we get the risk factor in poor countries, could be said, we have compound causes, in this occasion, tobacco smoke and pollution. We also are watching that smoking in cooks is another cause. We have the biological effect, the mutations in respiratory cells, of course, we all know about it, and the health outcome, the lung cancer. We know this. The consequence, the lung cancer, following all of these previous situations. And now let's talk about medical ethics. We all know this meaning, we all have the idea what we are talking about, and medical ethics is very important for us because we have to take our priorities in order, our thoughts in order, and the way we grow up in order to realize what we are doing at the moment while assisting people. Assisting an illness, assisting a disease, it's a situation that sometimes as a doctors can lead us against to the wall and the sword. So we have to be sure what we are going to do. Of course, following laws, following our thoughts, following how we are prepared to be with patients. It's not easy. Medical ethics is concerned with the obligations of the doctors and the hospital to the patient, along with other health professionals and society. The health professions has a set of ethics applicable to different groups of health professionals and healthcare institutions, of course. We follow rules, we have our own rules And we all know our 4 pillars of medical ethics. We all catch this idea at the beginning of the career. In Cuba, for example, we have a full class that was philosophy. That was that way of thinking in socialism, considering these four pillars of medical ethics and practicing all of them with many situations. We have the pillar of beneficence, non-maleficence, autonomy, and justice. In many countries, autonomy is out, is forbidden, and well, it's not applied. The pillar of beneficence, of course, we got the information. The pillar of beneficence is about promoting the good of others. We all know we have a reason to be a doctor. We have to do and to give our best in order to help our patients and the rest of the society. In medicine means acting in a way that helps your patients, always being doing the best. The most obvious example is of this providing up-to-date evidence-based treatments to your patients with the aim of reducing their symptoms or treating their illnesses. We have to stay studying through our complete life. We cannot stop this and avoid information and dismiss all the new research. We cannot forget this. Following the evidence-based treatments, we have the support for doing new treatments, for applying new procedures. And well, that's a good point of view. Many medical schools don't apply these evidence-based treatments because they consider they are not focused on the topics that we have to look for. And it's okay, it's their opinion, but we have to choose where to work on. Evidence-based treatments, of course, give us the guideline, I think, for working correctly. In this blue chart, I'm showing you some examples about the pillar of beneficence negligence, just for reading and taking vocabulary of this. It's an interesting case. And well, while you read this, you can see how unfair was the situation in past, and not a long time ago. You can see not even 100 years ago, less time, we had some research without looking the beneficence of our patients, in general, and lots of people has to be dead just for getting this new information and changing the rules for looking for the benefits. Okay, just read this and you're going to catch a good history, I think. The pillar of non-maleficence. Non-maleficence refers not to causing harm to your patients, of course. We have to be sure what we are doing to do it. We have to recognize that we have a title. We are supposed to have the experience and all the capabilities to develop this job. And then we are prepared for not harming. This principle spans a range of applications, such as doctors maintaining medical competence and not giving patients treatments where the risks outweigh the benefits. We all have this idea in mind, right? But when we get in practice, it changes where we can see this. It seems obvious that doctors would not want to harm their patients, but yet there are countless examples of when this principle has been disregarded. We have lots of experiments of situations that talks about maleficence. We don't follow this pillar of non-maleficence, I mean. Lots and lots. And we have this one that is showing us how doctors were killing patients in order to reduce the country costs, the healthcare system costs, because they were elderly, and it's not acceptable to do that. We have examples from doctors that just for taking some money change the diagnosis of patients and apply expensive treatments just for helping their money incomes, yeah, without checking the danger, the whole situation that they're causing. So read this, it's important, it's interesting, just as an information, of course. About the pillar of justice, of course, as doctors, we try to follow this. We try to use justice in the benefit. Well, it refers to fairness within medicine and equal distribution of resources. We try to help our patients. We try to do our best with everybody. We might have the knowledge, the capabilities, the experience to do this, but well, we have to try that equality and equity of healthcare across patients not always is present. In this chart, we have equality, equity, and justice. Okay. And we can see the difference of them, taking in account what is the best for everybody and what is the best for the group, or what is just giving a benefit just to some of them and one is avoided. So in that order, we have to take it in account, and it needs the country support, I think. It needs our healthcare rules to be done in another way, but well, it's not easy. But we try to do this, I promise you. About the pillar of autonomy, of course, self-determination. In my opinion, it's one that I don't really like, but we have to follow this, no matter if it's correct or not in some cases. We have the final pillar, and it refers to a patient's right to make their own healthcare decisions. The patient has the last word at the end of this, because it's own body. They need to know what is happening, and they need to know the consequences of a treatment, of a procedure, and they have the chance to take the opportunity to give us the decision what we are going to do with them, or a family or a relative, I think. And taking it in account, we have to consider that not always it's easy to understand this. It's not easy to get to accept that patients can choose or can make a wrong decision. And we only have the option to accept this, to accept it, and say, okay, I'm gonna do this, no matter if I'm against of this. We have to remember that autonomy is not for everybody. We have some situations when doctors can take the decision instead of patients, but are very punctualized situations. When we talk about mental disorders, when we talk about critical situations, for example, CPR is at this moment a very huge point of discussion, because that's a new wave for patients to get in a tattoo and in the heart area, and they said don't apply CPR, for example. But what you do, apply or not apply? It's loyal, it's not loyal. It is correct not to do anything. We have to choose at the moment. In my opinion, personally, I choose to do, and then follow the consequences to do something that maybe the patient doesn't want. But the objective is save a life. Okay. In some countries, in communism countries like Cuba and Korea, North Korea, this pillar of autonomy, it's not present. We have to be clear on this. Well, as you know, I studied in Cuba. I had the opportunity to get a scholarship there, but while living there, you have to be full open mind and be a thinker, not just follow the rules and do everything the way they say. You have to read and get in information. And when you see that living in a dictatorial system, you understand that autonomy is not allowed in order to preserve the healthcare system and all the rules they follow. For example, in Cuba, if you have a situation that has to be income at any hospital, for example, an oncological hospital, because in Cuba there are specific hospitals for oncological patients, there is no way to ask for leaving the hospital. At least the doctor gives the order. There is no way. You cannot go to your family and say goodbye. You cannot receive visits if doctors consider that it's not a good idea for you. No matter if you are dying, you cannot receive just palliative care. You have to stay into the hospital. And well, of course, we all know that the terminal period of cancer, for example, being at the hospital could give us a huge depression. So in that order, it's not a good idea, in my opinion, but there are the rules. There are the rules that as a country they decided. So it's different in the rest of the countries, in free countries, I mean, sometimes as a doctors we feel with our hands and without movement because we cannot choose against, or maybe with children, we cannot take a decision. For example, in Jehovah's Witness, so they refuse blood transfusion because the religion grounds. We all know about this. We all know they don't receive the blood transfusions because they consider that the soul is into the blood and they don't want to receive the soul from someone else. So it's difficult not to apply this treatment if we see that the child is suffering from this loss, and well, just wait that a miracle could be done. So it's difficult. It's an ethical challenge to understand this, or maybe to get the consent of the patient. About the consent, we have the General Medical Council guidelines. These guidelines are some rules. Here I'm showing just 9, but there are around 20, I think, at this moment. This is a file that is showing us how we could, well, which rules we have to follow. It's very useful in Europe, specifically in UK, France, Italy, and Germany, I think. Germany was there, and India, I think. And some of these rules are useful in USA, Mexico, and some countries in Latin America. I'm not sure about Latin America, that's why I'm not mentioning them. Some of these duties are, of course, an obligation to follow, to get in mind, to keep as a ritual, to remind them and practice with them. So read this and take the vocabulary. It's important to get ideas of this, to get a new vocabulary, because, well, in any occasion you can use of this. For example, professional competence. We all know what it means. To recognize the limits of our professional competence. Sometimes it's not easy to follow in some countries because of the resources we have. And some doctors, especially in the emergency room, we have to take the decisions like a specialist from another branch. But well, that's the risk we follow. About the bioethical issues, we got the idea about it. We got the meaning, and well, we have some terms to remind. For example, the euthanasia. Euthanasia is such a big problem because why we have to decide, or why we have to decide or to help a patient to end its own life. How you can do this? How you can deal with this? To go and patient to live with an assisted suicide in order to finish in pain, to finish a long disease, or well, how you can do it. But maybe when your relatives are asking for euthanasia because you just have not a purpose. Of course, the first step of euthanasia is that the patient has to be sure on the step he's going to take, has to be sure on the decision he's being informed, and well, the relatives have to understand that it's a patient's choice that has to be supported by them and has to be developed by the doctor. So, in which moment you can choose when to finish a life? That's a good question. About human fertility, again, we always have been the trouble because how ethical could be to use the in vitro fertilization or about the surrogate mothers. So to be a surrogate mother, of course, you as a mother are just the body that is taking the baby, and you are living the pregnancy, but the baby is not yours. In which moment we try to do that? Okay, so about embryos and if they can be frozen or not, or they can be implanted to another mother in a later date. So they are questions that we have to consider and to take in count. Just take in count and practice with them. About transplant surgery, it's a very good question because who should give the consent for removal of the body parts for transplant surgery? The patient, the relatives, our healthcare programs. Which one has the option to choose that? Or the genetic engineering? About cloned, copied exactly. Replace the clones are a big trouble at this point, but of course they are happening. Just it's a personal question to answer. About the assisted dying, we have this chart that is showing us some vocabulary to practice, to check. And well, we have to consider this. When to decide this, we have some ideas when it's better to apply. And well, it's just an example how to do it. For example, in the persistent vegetative state, the patient is not going to choose. Are going to choose the relatives. So artificial feeding, artificial life is not a way of living. It's just a way of surviving, for going on and not staying. So patience, just keeping patience and read this, please. It's going to be helpful for taking vocabulary model expressions or phrasal verbs. And don't forget it, keep educating yourself. Very important area. At this point, any question? Something you would like to say, maybe? Something to add? Well, if there's no questions, I sent you the poll to take attendance. And tomorrow we have an activity to take it in count in order to talk about it. Maybe just as a discussion, I think, for catching few concepts and ideas and vocabulary, and that's all. Well, I need 3 students more. Hey, thank you. Hi. Does all of you can watch the poll? Is someone?
I didn't receive the poll, sorry.
Okay, I'm gonna send it again.
Thank you.
Okay, let me relaunch this because I think you are the last one. Okay, can you watch this, Denise? Yes.
Yes, yeah, I already sent.
Okay, perfect. So let's close this. So that's all. And don't forget, tomorrow during the workshop, we are going to have an easy job. Yeah. We can still check homework or a detail you need from the previous slides. And that's all at the point at this moment. So see you tomorrow, everybody.
Bye.
Bye-bye. Well, at this moment, I finished with everything. Yes. I'm sorry because I'm without my camera, but I'm having some troubles with this device. Well, I have to correct it again. Well, at this point, I know that Gabriela Agreda and Natalia Aramayo are at the university. I have no notice from Liana. Well, Karen didn't say anything. Luis, it's a surprise. He didn't attend today, but well, he might have a personal situation, I don't know. But the rest of the students were here, and that's great. So see you tomorrow during the workshop. That's all. Goodbye.